Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for May 27th, 2021. Today's CME activity code is 482407. We have a great case today. Dr. Whittier is going to be presenting to us. As usual, we don't have any conflicts. The patients are all de-identified. I'd like to welcome anybody that's new here today, especially Dr. Wadi Suki. It's great to have you join our conference today. Dr. Suki is a nephrology icon, clinical and research, and it's a joy to have him here. So welcome aboard, and I think let's get started on the case.
Thanks, Roger, and welcome everybody. So this patient's a 75-year-old Hispanic woman with past medical history of high blood pressure and diabetes for about 15 years. But she didn't have very good follow-up. She originally presented to the emergency room when we met her with complaints of dyspnea, cough, anosmia, and she had known sick contacts with her children who had COVID-19, and she lives with her children. So she initially presented those 6 months before all that to her primary care physician, and at that time, her creatinine was found to be 2.03. Before that, they didn't know what her baseline renal function was. Her urinalysis was bland. She had 3+ protein, and her urine AC was 2.6 grams per gram. 3 months later, her creatinine had gone from 2.03 to 2.73. And then 3 months later, when she came in with COVID on admission to Rush, she was requiring oxygen. Her creatinine was all the way up to 5.8. Her urinalysis at that time demonstrated 1+ blood, 3+ protein, and the urine albumin creatinine ratio was 3.7 grams per gram with a urine protein creatinine ratio of 5.5. So during the hospitalization, she was treated with supportive care, and she required oxygenation, she required intubation, she also required hemodialysis for 3 sessions. Eventually, once the effects of COVID-19 were worn off, her oxygenation improved, she developed a little bit of renal recovery. She fortunately remained non-oliguric the entire time, and her creatinine stabilized around 3.7. So she was sent home off of hemodialysis, and about a week later, though, some of her workup came back, which is below. We'll go through that. But a week later, she went from her 3.7 when she was discharged back up to 4.5. So at that time, that plus her workup below, we decided we should probably pursue a kidney biopsy. Her blood pressure the whole time remained well controlled. She didn't have any symptoms of anything that was specific. She didn't have any lightheadedness, any dizziness. She denied any use of NSAIDs or herbal medications. She had the classic COVID presentation, but she was actually improving on her review of systems. When we saw her again, she still had fatigue and still had anosmia, but her breathing was much better. Her hypertension for 15 years and diabetes have been relatively well controlled, but we don't have labs as far as baseline creatinine besides, 6 months ago. She does have no retinopathy, neuropathy, or gastroparesis. She has a family history of diabetes as well. Her medications were lisinopril, carvedilol, amlodipine, aspirin, and metformin, and insulin. The metformin had still been on hold during her hospitalization. Her blood pressure, when we saw her, was 138/73. She was 136 pounds and 5'3", so she was small. Her BMI was, I think that came out to about 23. She was alert and no acute distress. She still had some rhonchi in her lungs. She had a 2 out of 6 systolic murmur. She had non-displaced PMI. She had trace pretibular edema and no synovitis, no rash. So when she came back to Rush, again, her creatinine was 4.5. Her bicarb was 20, chloride 108. Her albumin was 2.9. AST, ALT were fine. Her hemoglobin was 7.6. Her ferritin was still quite high, consistent with COVID. She also had a mildly high LDH. Her serology showed for her age, her ANA was, it was 1 to 80. Homogeneous pattern. Her double-stranded DNA was negative. Her rheumatoid factor was 15, and our reference range goes up to 22. So that was within our reference range. She had mild hypocomplementemia. Very mild. Her C3 was 78, and our reference range there is 82 for our lab. Her C4 was undetectable. Her double-stranded DNA was negative. For the infectious workup, with the exception of COVID, that was negative. And her urine findings showed 4+ protein, 1+ blood. She had 8 red cells, and her urine AC and PC are there, as we also said in the history of present illness. Her SPEP and UPEP came back with a monoclonal IgG lambda, both in the serum and the urine, and her ratio was low, consistent with an elevated lambda. Her renal ultrasound showed a right kidney of 11.3 and a left kidney of 12.5 centimeters without anything else that was remarkable. And so we did a percutaneous renal biopsy.
Did you get an echocardiogram at all?
We did have an echo. In fact, it happened during her admission, and I didn't go into her whole COVID admission, but she actually had a troponin elevation during her COVID presentation where her troponin went up to 25. She underwent a cath during that admission, and it was negative for coronary disease. Her echo was also fine. She had an ejection fraction that was 55%. Was there something? No vegetation.
Yeah.
Any other questions, anybody? Okay, well, we have a birthday in the house, Dr. Baxi. And you can't tell because he's blurred his background, but it's full of balloons from his wife. There you go. So I'm going to let the birthday boy discuss the case first. Pravir, you want to take it over?
Yeah, absolutely. Wonderful present. So we have an older lady. We're basically working up her AKI, and it seems like she has CKD based on both her past history of long-standing diabetes and hypertension. Even though we don't have much data on her back more than 6 months prior to her admission, she had a creatinine of 2.03. Based on her history, I would have to suspect that she has some chronic kidney disease, but she has an acute elevation, AKI, and she has now nephrotic range proteinuria, which is worse than from the baseline that we know of. And so the biggest things here are, in terms of the AKI, what stands out in her history, of course, is, the COVID. So she presents with COVID and her proteinuria goes up. We now know the related AKI symptoms with COVID, including Covan and Covaci. And so, Covan, typically, with these patients who have Covan, they get, severe nephrosis, their albumins go to the floor, and, most of the patients that we did see don't do as well with them on the limited data that we have. But it seems like, her COVID kind of improved, and she was improving, and then she presented now with worsening AKI. So, that is on a differential, but it seems to be, maybe just a part of her, not in terms of COVID, but maybe she had COVID-related AKI, and we're seeing ATN. But again, I think her COVID was improving, so that's something that doesn't completely tie everything together. And then, of course, we get her serology.
Pravir, can you just say, I'm not sure everybody in the audience knows the word Covan.
Oh, so Covan. So in terms of collapsing FSGS, I'm sorry, we just get so used to saying it now a year later, but the association of collapsing FSGS with COVID-19, similar to what we've seen with other viruses such as parvovirus, HIV, and including medications, pamindronate, lithium. We get a collapsing FSGS, and these patients, we've seen some patients who do get it as they're improving for COVID, but now, when patients have respiratory distress, as she did, they're getting steroids. Now, we don't know if steroids help in these cases of Covan, but, they have been used for other causes of collapsing FSGS. But, again, so I think that anytime we have a patient who has COVID and they're presenting with, acute nephrosis, collapsing FSGS, or I guess the term Covan now, it has to be on our differential.
So Covan stands for COVID-associated nephropathy, just like HIV. It came from the terminology of HIVAN, which is HIV-associated nephropathy.
Mm-hmm. So, then we do a workup as these patients, and of course, the biggest thing that stands out there is the monoclonal IgG and the lambda in the serum and urine. Given her age, that definitely is a big finding, which, that's why the biopsy was pursued. And, that brings up the differential of a monoclonal a paraprotein-related kidney lesion. And that could range from, anything from amyloid to we've seen, organized deposits on biopsies. There's a whole evolving literature of so-called, monoglobal gammopathy of renal significance if it doesn't fulfill the criteria of a myeloma or a true, and so the MGUS and MGRS becomes on this differential. Now her kappa lambda ratio is in fact normal, but surprisingly, we typically see the kappa lambda ratio a little higher, where the kappa is higher than your lambda and CKD. So, the ratio of 1 with the severe CKD is not the typical, but again, I think ultimately MGRS is on the differential. She does have some blood in the urine, and she has primarily glomerular proteinuria with a UPC of 5.5. And so I think that's another thing to think of. The ANA slightly positive with a low complement. Sure, it could be maybe an immune complex or complement mediated lesion. I think that's less likely. The C3 is just barely below normal, but that's another thing to consider. And finally, with diabetes, the two other lesions that we see commonly associated with diabetic nephropathy, IgA and membranous. IgA is another possibility with her, given her background. And maybe she's had IgA all along. Why would it get all of a sudden worse? I think that wouldn't completely explain the picture here. And then membranous could explain the proteinuria, but why all of a sudden has she had a worsening of her kidney function? So, ultimately, those are things I think about here. So, do I think she's going to have background diabetic nephropathy? Yes. I think based on her 15-year history, even though she has no other, no retinopathy, neuropathy, I think we will see background, at least mesangial diabetic nephropathy. The question is this just progressive disease or is there some other acute lesion that's reversible? And I think, diabetes and ATN are things that I think we'll see. Will we see something else is the big question here. For me, I think, for her, I think it's going to be, I'm going to put bad diabetic nephropathy with ATN as explanation of her acute worsening, and the ATN in the setting of her illness in COVID-19 I'm going to put that number 1. 2, I'll say maybe she'll have a MGRS, a monoclonal lesion. She does have this monoclonal IgG lambda, so that is number 2. And then 3, I would put in a membranous along with diabetes, just because she has a little blood, her age, and her nephrotic range proteinuria. But I ultimately think this is going to be diabetes and ATN with severe kind of background chronicity.
So what's common is common, and that seems certainly reasonable, except for the fact that, she gets better from her COVID and she continues to get worse, which, does bring up the question of a COVID-related lesion and not just ATN from something. Steve, what are your thoughts?
Man, I don't think there's much left to talk about. Yeah, I think Praveer's covered it really nicely. I definitely think she's going to have background diabetes. About 35% of type 2 diabetics don't have retinopathy and yet have significant renal disease. It was interesting that, when Ed and Mel looked at this in the ID&T study, when they did the ophthalmologic exams, what they found was that the people that had retinopathy were more likely to have nodular glomerular sclerosis, and the ones without had the more diffuse mesangial sclerosis. So, that may be what we see here is rather than nodular disease, but I definitely agree that there's got to be some, I strongly suspect there'd be some background diabetes. The thing I thought was kind of interesting was that, yeah, the C3 is a little below low, but the C4 is like undetectable, as Bill said. For me, that always becomes kind of a red flag for a cryo. And now, granted, kind of an indirect way of looking at that is the rheumatoid factor. And it's not all that high, but it makes me wonder that, if the blood clotted and it was cold, everything may have come out with the cryo. And so your rheumatoid factor may not be so high, but the low C4, maybe that's why I was asking about an echocardiogram to see if the guy had an SBE or if the woman had an SBE, and accounting for the low C with the cryoglobulin accounting for the low C4 and a glomerulonephritis as a result of that, which generally would be immune complex, but also could be Pauci immune. And the C4 being low is kind of an in vitro phenomenon from the cryo. So that was kind of one of the things that was kind of curious to me. And it'll be interesting. If they ever checked for a cryo to see but it's just something to think about. And we'll see what we, on the biopsy, we'd be looking for subendothelial deposits or intraluminal deposits and or subendothelial with organization. I think the COVID issue has been well discussed. I mean, the only thing I was wondering was whether there'd be some thrombotic microangiopathy related or to arteriopathy related to the COVID and the hypercoagulable state. But yeah, the big E on the eye chart is always this IgG lambda, and I think the ratio being low is, as Bill said, the lambda level is high. And all of the things that have been discussed. I mean, she's in the right age group, whether she has an MIDD, which would be amyloid light chain disease, plus or minus CAS nephropathy, especially with lambda light chains, is always a possibility. And the whole issue of MGRS in that situation, you'd find, usually either membranous or membranous proliferative GN with the monoclonal proteins being the antibodies that you find on fluorescence. So I think diabetes is definitely there. The question really is what else is coexisting, and I'm going to say there's ATN. And then third is amyloid. I just have a feeling that this proteinuria is from her diabetes, and the acute renal failure may be from the COVID. But I can't get away from the fact that at 75 years of age with an IgG lambda, I've got to put amyloidosis in there.
What about ALEC2, Steve?
ALEC2, that's always, I guess, a possibility. They don't usually have a monoclonal protein though, right? And it's usually, my recollection was it's usually more tubular interstitial amyloid than it is glomerular, and their proteinuria is often quite minimal. Because
it's tubular interstitial. Yeah, I see, Hispanic.
So actually, Roger, that's why that wouldn't even be on, my differential, because it's just like so far out in left field.
Yeah, well, we like to have a complete differential, so sometimes you have to add to your left field. No, I just see a Hispanic.
Wait, we put post-strep GN, I guess, in there too.
No, there's something. I mean, she's a proteinuric Hispanic older person. I think it's just worth bringing up. That's all.
No, that's a good point.
Bill, did you get a PLA2R?
No, we did not get a PLA2R, and nor did we get a cryo prior to the biopsy.
That low of a C3 is pretty interesting. I think, I've only seen it in a couple of things. C4, I'm sorry, thank you. Steve mentioned in cryoglobulinemia, which is an in vitro effect, and a complement deficiency, which makes you wonder about even an autoimmune disease. Dr. Glassick, do you have any thoughts about that low C4? What is that? Do you think that's a red herring, or?
Well, I think Steve has commented on the possibility that it's an in vitro phenomenon related to some kind of a protein that tends to precipitate and activate C4. It would be nice to see a C4 in a sample drawn at body temperature rather than lower temperatures, to see whether the C4 lowering is related to exposure to cold. That would be an indirect way of assessing cryoglobulinemia. The other feature of this case that kind of intrigues me is the very high ferritin, the anemia, and the mild thrombocytopenia. The hematophagocytic syndrome can follow COVID, and it is associated with collapsing glomerulosclerosis. Now, I understand the ferritin in this case may just be a leftover of the COVID infection, but I would have done a bone marrow to look for hematophagocytosis, because if that was found, the likelihood that this is collapsing FSGS is pretty strong. Even though the proteinuria is not massive, which it usually is, the patient does have pretty significant hypoalbuminemia. It's a stretch, and I would probably put it down below amyloid, but it is a consideration.
Yeah, the problem is we're still left with this monoclonal gammopathy, and there's different algorithms for approaching that. You could do a bone marrow first, and if you find something, then you might not need to do a renal biopsy, although that can be argued too. But so you could look for two things, but kind of in the end, we're stuck with a lot of these, and then they end up needing a renal biopsy.
If you're talking about a bone marrow for amyloid, you really need a fat aspirate and a bone marrow to get your sensitivity up above 95 or so percent. I don't know if that's what you were getting at, but
less specific. I just mean a bone marrow looking for some clonal,
gotcha.
Clonal population that might explain that might also be producing IgG lambda, which is what we're seeing in the serum and the urine. Dr. Rubin, you put a question mark in the box, monoclonal protein directed against C4. You want to elaborate on that?
Well, the group from Paris has reported that monoclonal immunoglobulins can be directed against complement components, trying to explain some of the cases they had of a typical HUS. So aside from what Dr. Glassett mentioned regarding the cryo and C4, I guess we have reached the stage where we should consider this possibility as well.
Yeah, that's a good point. We're learning more and more about all the different things that monoclonal proteins can do. Even interference on assays besides interacting with proteins. So that's a good point. Before I spin the wheels, anybody else have anything else they want to add to the differential or comments? Dr. Gashty, anyone? No. Okay, let's put the wheel up.
There you go. That's great.
Oh, I got to work on that. All right, I guess it's me.
Go ahead and click on the screen, and then you'll have control here. Give me a second, actually. Yep.
Great. David, you on?
Yeah, I'm here. Can you hear me?
Yep, great. Okay. So we've got two cores here. You can see there's a fair amount of interstitial fibrosis. It's actually kind of interesting. They got some, I don't know what this actually means, but a lot of blue staining material here, and that these little areas of tubular atrophy, you've got around the glomeruli, you almost see no tubules, and then you've got these other areas here. Regardless, it's got to be 80% fibrosis.
Yeah. Those areas you were focusing on were preserved functioning tubules.
They just look a little darker to me, but okay. It is it's odd though. How kind of patchy. I mean, it's almost striated there, the way it's got these islands of tubules and islands of fibrosis, but be that as it may. The glomeruli, there's a lot of sclerotic glomeruli in here, but there are some definitely intact that we'll be able to look at. This is a trichrome. And here we have a single core. This is an H&E, David?
Yeah.
Okay. You can see here several glomeruli, some of which are sclerotic. You can see some tubules around the glomeruli that look pretty good. We'll see them on higher power.
Yeah,
and there's some interstitial nephritis down here as well, but this may be associated with this dying glomerulus.
Yeah, there's a dying dead glomerulus just to the right of that infiltrate. Yeah. But I mean, we're talking about paraprotein-related kidney disease. Do you see any evidence of myeloma, cast nephropathy?
Well, certainly, yeah. I don't think myeloma was high on the list, but a very good point, David. Yeah, I don't see any fractured casts in there, so I think that's worth bringing up, regardless. Here we have a PAS, and you've got a glomerulus that's pretty sclerotic over here. You've got one middle involved and one that's a little less involved. But even in these two that aren't completely sclerotic, there appears to be some mesangial sclerosis. It's a little bit nodular here, but it doesn't look super nodular to me if this is diabetic nephropathy, but there's certainly a lot of mesangial disease. it's fairly highly PAS positive in the mesangium, and amyloid at least tends to be PAS weak. So that doesn't completely rule it out or rule it in, but just kind of thinking ahead. Yeah, these casts look fractured.
Yeah, I was about to ask you about those.
Oops. They're fractured casts. That's all I can say. So we'll have to look at see if that's also lighting up on immunofluorescence or if they're just Highland casts. I think, you know, David, when in myeloma casts, they're not usually that PAS positive. Would that be correct?
Right. Yeah, and they're associated with a giant cell reaction is another feature.
Yeah, if you happen to see that, but these look pretty, you know, they just look a little dark for cast nephropathy, but considering the diagnosis is kind of funny.
So Roger, you may have said this, but do these gloms look lobular at all to you?
Not especially. I mean, well, it doesn't look as nodular. I mean, this looks a little lobular here, but I'm not that. I'm
thinking more like an MPGN type appearance. That's all I was.
Yeah, not especially. Does it to you, Steve?
A little bit. That's why I brought it up. I agree with I think there's mesangial expansion, but it seems almost too cellular even to be like nodular diabetic glomerular sclerosis. But as I look at the one glom to the right of the two down in the left corner, it looks a little lobular, and actually the one on the left does, but that's just me.
Yeah, I can see your point. We'll see. We'll get a better look. So there's some tubules here. Look at them at higher power, but they don't look that normal. I don't see a good brush border on them.
Yeah, and then above that, there's a good atrophic tubules. Yeah, with wrinkle-thickened basement membranes and interstitial fibrosis up there.
Yep. Good. Thank you. Oh yeah, right here. I'm sorry.
Yeah.
Yeah. Thanks, David.
Yeah, associated with that scarred glomerulus. Yeah.
And here's a real mess here. There's a lot of interstitial fibrosis here, almost no tubules left, some cells, these are vessels.
Yeah, arteries, yeah.
Arteries with what looks like, you know, some hyalinosis.
Yeah, some sclerosis.
If this was a glomerulus, this is the mother of all capsular drop lesions, but I don't think I think it's an old just fibrosing glomerulus, correct?
Yeah, in fact, you could count 1, 2, 3, 4, 5, 6 scarred glomeruli in this little focus here. And so, yeah, there is a background of a lot of chronic kidney disease. 35 out of 50, 70% are globally sclerosed in the biopsy.
David, is this a vessel right here?
Yeah, I think that was the hilum. Yeah.
Yeah, so that's a pretty, you know, there's an awful lot of thickening there, a lot of, you know, hyalinosis of that vessel. Yeah. Certainly consistent with, not pathognomonic, but consistent with diabetes. But no surprise, we all knew she had diabetes for a long time. And that's not why we did the biopsy. We did the biopsy to look for, you know, a monoclonal related disease or a collapsing FSGS or membranous or IgA, a very broad differential that was brought up. Here's another PAS. And you can see you can see the mesangial expand with fairly strongly positive PAS material, which again would be unusual for amyloid. Amyloid tends to be PAS weak. Bowman's capsule itself is a little thickened as well. So this is mostly, looks like a mesangial disease with PAS positive material, which would be very consistent with the mesangial variant of diabetic nephropathy. The tubules here, you know, they don't look normal.
I don't see brush borders on them. Yeah. There may just be some preservation artifact. You know, if it doesn't get into formalin right away, you start to get some early autolysis of the tubular epithelium.
Yeah.
In this mesangial, Roger, do you think there's, because IgA was there, you know, is there hypercellularity there? You're saying it's mesangial expansion.
That's a good point. I should have mentioned that. I mean, there's not a lot of cells. I mean, if you look, there is, but these are pretty broad mesangial areas. But I think this is more just material than cells. You know, they have described even in mesangial diabetic nephropathy, a slight increase of cells. It's not considered a cellular lesion, but there's been, you could see a couple extra cells. So if this was this much mesangial from IgA, I would expect more cells. David, you agree?
Yeah.
Okay.
Yep. Yeah. It's looking like like you said, a diffuse mesangial diabetic sclerosis.
And kind of the same thing here on this glomerulus, maybe a little bit worse.
Look at the vessels, though.
Yeah. There you go.
Both, well, my bad.
If these are,
yeah,
I don't know if these are the afferent and efferent, that would be, if this is the hilum, then that would be very consistent with diabetic nephropathy.
Yeah, because over at 5 o'clock, you have another arterial that I think is distinct. Yeah, right there.
Yeah. Yeah, regardless, I mean, it's pretty impressive hyalinosis. And, it looks like there might be some ATN going on in some of these tubules. This is getting almost to a segmental scar here. It looks a little bit worse on this side than it does here. I don't know what the context of that is in the setting of someone with this much disease. It would be difficult to say there's a primary FSGS lesion, but David, do you agree this is more of a segmental lesion here?
Yeah, you got some hyalinosis there. That shiny
and maybe even a
adhesion.
Adhesion, yeah, good. But that can always be secondary, so it's a little difficult to say it's a primary lesion. Here we have a silver stain, not the best glomerulus we're going to find, but I don't see any double contours. I don't see any holes or splits. I just see a lot of mesangial, expansion. I don't really see much here. Other than what we've described on light. So, of course, it doesn't rule it out. We'll have to see the IF to get a complete view. And so the IgG is negative. Now, we often see some linear.
It does look like there's some linear there.
It is pretty weak. I don't know if this patient was diabetic, if I would be even saying that. But I mean, you look here and you look here and you look here. Yep. It's there's some very weak linear, pseudo-linear pattern, and it's in the tubules. It's in Bowman's capsule too. So that certainly goes along with again diabetic nephropathy.
Yeah, and the kappa lambda light chains were negative. There was no monoclonal staining.
What about the Congo red, David?
Negative for amyloid.
Okay, good.
Well, so what's ruled out is at least amyloid, and ruled out as a monoclonal gammopathy. And, I suppose, and probably membranous, because we would have seen something in the IgG. And now we're pretty much left with, our silver stain. And here you've got this markedly expanded mesangium, and this is the blood space, and this is the urine space here. And looking at the basement membrane, we'll see it in a higher power, but I don't see any deposits there. Again, blood space, urine space. I can't tell if they're thick at this power, but certainly the mesangium is widely expanded, and we don't see any mesangial deposits either, along the lines of Bill's question of IgA when we saw the mesangium, but the IgA was negative on the immunofluorescence anyway. I suppose this, Dr. Rubin said they'd look thick to him, but David always gives us a measurement, so I think we'll be able to get a better idea how thick they are. They're certainly not thin, but
yeah, we expect them to be thick and diabetic.
Yeah, 494 is getting up there, so yeah. They are thick. If you look at the foot processes, they're pretty well effaced here. Pretty diffusely effaced. There are some intact. Little bit here and maybe here, but quite a bit of foot process fusion. And then the basement membrane is thick, and I don't see any subepithelial or subepithelial or intramembranous deposits. Or fibrillary structures, suggesting organized deposits, suggesting a monoclonal related disease. So I guess the diagnosis is advanced diabetic glomerular sclerosis, the mesangial variant. Steve had brought up Dr. Lewis's paper years ago that in the patients that that we were able to look at that we biopsied for the IDNT, that there was a stronger association of retinopathy to Kimmel-Steele-Wilson disease. This was more of the mesangial variant. And for what it's worth, it does fit the, the non-retinopathy pattern that he described. And I think that's our diagnosis with very advanced glomerular sclerosis. If there was an element of collapsing GN, I'm not sure, we didn't see it, but I'm not, you might have needed another 20 glomeruli to maybe pick it up. And there was some ATN to maybe explain the AKI. I'm a little surprised it's continuing to go on. And so, I suspect, as was originally proposed, this is diabetic nephropathy with a lot of other insults, including being sick in the hospital, on dialysis, and ATN and COVID, and Covaci, which is what we're calling COVID-associated AKI. So that's my diagnosis, and I'm sticking with it. Bill, how do you interpret this case?
Do you want to ask around about treatment or anything, or?
Well, is there? Yeah, I can ask. Casey, what would you do for this patient?
Just supportive care. There's nothing, besides our standard management of diabetic nephropathy, RAS blockade, blood pressure control, glycemic control, SGLT2 inhibitors. Not right now, obviously. There's a lot of hemodynamic changes with COVID on board. And is the patient still on dialysis, or she's off?
She's off dialysis right now, but
okay.
She went from 3.7 to 4.5 in a week.
I mean, would you use
with AKI, I would probably not do any of those things. I would just wait and see what happens with the ATN and just wait for that to recover. And then I would go back to the standards of care of diabetic nephropathy. Nothing here to treat with regard. Obviously there's no monoclonal related lesion in the kidney. So that diagnosis still remains MGUS. And there's also does not seem to be, it could be from COVID. So there is COVID associated AKI, but there is no COVID-associated collapsing FSGS. So again, nothing in addition to just support.
Would you use an SGLT2 in her at this point with her GFR so low? Yeah.
No, she's an AKI. Her creatinine is going up. Definitely not.
Yeah, and I think it's not that it's 100%, but her GFRs, I think it was only the studies that were GFRs above 30, and she must be below that. But I think you'd be asking for trouble. I think Dr. Gashti's right.
So how much ATN did you see, David?
Patchy.
Because, you and Ed had that abstract, which never got published, but other people have looked at it. Even when the creatinine in a diabetic is 1.5 or 2, they can have significant interstitial fibrosis. And that was the part. It's almost as if there's no good correlation to it. It was far more widespread than what the creatinine would have led you to believe. So, some of this chronic disease may have even, been there when the creatinine was whatever it was, 2.5 or whatever that baseline was 6 months before she became 5. And I just wonder how much the 5 is more ATN, and that might get a little better over time. And that fibrosis, may have been there even when the creatinine was whatever, 2.5.
Would anyone do a bone marrow?
No. I don't see any reason to do it now.
Sorry.
What about hemophagocytic?
Hey, Steve or Roger, I wanted to ask you about the fact that her kidneys were of normal or even slightly enlarged size.
Oh, that's an easy one.
Yet you see all this fibrosis. You wonder that is not a manifestation of a diabetic patient who has large kidneys that has shrunk a little bit, but that if you had measured her kidneys 2 or 3 years ago, they might be 13 or 14 related to diabetes.
No, I think that's a great point.
We now have the capacity to assess fibrosis non-invasively by elastography, MRI, or ultrasound. I'm just asking the question, if you see a patient with somewhat large kidneys, but very stiff and fibrotic kidneys, would that not be a sign of diabetes?
I guess that's a good
I'm
point.
putting two things together here that aren't necessarily related: kidney size and stiffness.
But you could see that in
And,
amyloid, I would think, as well, right?
Well, yes, and I'm looking at this biopsy and tremendous amount of fibrosis and scarring, yet the kidney size is normal.
Yeah. Well, I actually think it's on the, for a lady that's 75, I think 12, what was it, 12 and 11 centimeters is actually large. I mean,
yes,
at that point, you would expect it to be closer to 9 or 10 centimeters. So
right.
I agree with you. I think, I think the diabetes goes along with that. And it could have been that they were larger before. Now they're somewhat smaller, but they're still large. But, you know, it would have, you know, before we knew what the ultimate diagnosis was, I mean, amyloid would have fit very nicely into that as well. You know, the other thing people talk about is HIV-associated nephropathy. The kidneys aren't usually large, but they're normal in size rather than being small.
Right.
But no, that's a good point. I have to admit, I don't know that I'd have to defer to the younger guys in the group, like Bill and Casey. Have you gotten that kind of imaging study to assess the fibrosis?
I've never heard you refer to the younger guys in the group. I think you're growing. This is really
well
impressive.
now that Praveer's 30 plus years younger than me, I really feel old. So
maturing. I really like it. No, I've not used that test at all. I'm learning as I always do from Dr. Glassick. Thanks.
Yeah.
Well, yeah, I haven't either, but I see hepatology orders it all the time. It's a routine part of their pre-transplant evaluation.
Yeah, that's a good point.
So they ordered on the livers?
Yeah.
Is that something you think we could actually order?
Well, if they can.
Oh, that's really interesting. We should talk about that a little bit more.
Yeah, that's.
You know, there are some isolated reports in the literature about it, but the group at Emory and Kim Celeste have dedicated the last several years to the study of interstitial fibrosis. And I think they're concluding that that might be the way to go. But as Roger would say, it's not for prime time yet.
That's
my new catchphrase. I like that, Mario.
I can't believe it. Rodby's so well known now. They're quoting phrases that he says. This Twitter thing is really unbelievable.
Yeah, we don't want to quote them all.
Yeah, thank you, Bill.
Sure.
Bill, why don't we move on to something more educational? Why don't you tell us what your thoughts about this case is?
Sure, thanks. You know, I think certainly there's a lot of ways to discuss this case. I mean, you can discuss it. When do you biopsy a patient with diabetes? You could say, when do you biopsy a patient with MGUS? And since the MGRS paper just came out this week in the New England Journal, I thought I would just tackle that one. So let me
go ahead. Yep.
Forward here.
Yep.
I got it there. So, you know, initially this was the paper that was constantly quoted, you know, during my fellowship and afterwards, which was Fogo's paper on how often in patients who have a kidney biopsy with an MGUS, how often is it related to the monoclonal gammopathy or not? And how often is it completely unrelated? And it was, you know, every time you find something in the serum, you're getting very excited that must be on the biopsy. And this really kind of sent it the other way. What they found in their group was that 63% had an unrelated lesion. So only 40% of patients with monoclonal gammopathy and renal disease actually had a lesion. And then fast forward another almost 17 years, and the group in Mayo looked at it as well. And you know, with all these new definitions of MGRS and all the new C3GNs and glomerulonephritises that are associated with MGUS, there had to be a lot more, especially with our fine tuning as we've moved on with time. And so they looked at the same thing. They looked at all their patients with an MGUS that had been biopsied, and that after all their exclusions, they came out to 160. And lo and behold, they actually found the same thing. So Agnes's original, or Dr. Fogo's original paper held up, and that 60% again were non-MGRS related lesions. And only 40% were related to the monoclonal gammopathy. And so what they also did was a multivariate analysis to look at, how likely is it that your monoclonal gammopathy is going to be a MGRS? And really the main things that came about were proteinuria was significant, hematuria, interestingly, and an abnormal free light chain ratio. Now, in the article, they quoted as an increased one, but we all know when you have amyloid that it's going to often be normal or even low. CKD will often raise it about three times normal, just because of the way that kappa is filtered compared to lambda. So we often, when you have a lambda, we'll see a low ratio, and that might be, and that's why I think they kept it here as abnormal. So it's not just a high ratio to look for. Interestingly, here also in diabetic patients, it didn't reach negative statistical significance, but it was it looks like there's a trend there that if you have diabetes, you're more likely to not have a monoclonal gammopathy of renal significance. And interestingly, let's see if I can share my screen here real quick. I don't know if hold on one second. Oh, I'm on back to screen. That's okay.
Yeah, I can. You want me to stop here? Go ahead.
Okay, cool. Thanks. Yeah, so I was kind of also looking in somebody who has a monoclonal gammopathy and they have diabetes, and that's from this paper as well. How often is it that a diabetic with a monoclonal gammopathy will have a lesion unrelated? And in this article, they looked at that. Of all the patients who had diabetes and a monoclonal, they found that 78% right here had lesions unrelated. So I think that in our patient here, this really falls into that category. We had, somebody who did have quite a bit of proteinuria, but did not have and I'll take the screen back if I can. Yeah, perfect. But had diabetes, so it was a little bit less likely to have had a significant lesion related to the monoclonal protein. We did ask hematology to do a bone marrow, or we asked them to evaluate, and they said no. Just like Dick had said, no, there's really no need. There's nothing in the renal disease, and the lambda is probably just a monoclonal gammopathy of unknown significance. So, but I did want to talk a little bit, just because of this came out now in the New England Journal this week from the Mayo Clinic. Again, all the different mechanisms and an incredible update. And I put this in the chat as well on all the different mechanisms of MGRS. So when it is, when your monoclonal gammopathy is associated with nephrotoxicity, we of course know about amyloid, light chain proximal tubular disorders with either crystals or damage itself. Thrombotic microangiopathy can exist. We know that you can actually have an absence of light chain restriction and still have a MGUS be affecting your complement pathway. And most often we see this with C3 glomerulopathy, but even Mario said in the chat that possibly C4 should be considered, as well as the proliferative GN and the crystal globulinemia, which has been discussed before on the ASN communities pages. And this is a really, really nice picture that just kind of localizes all the different parts that the MGRS can be affected. You have your TMA, you've got your amyloid, which can be vascular or glomerular. TMA could also be in glomerular. Light chain deposition disease, not just in the proximal tubule, but also glomerular, immunotactoid, the light chain proximal tubular disease here, the proliferative glomerulonephritis associated with the monoclonal gammopathy as well, and then C3GN, which again is one where you don't actually have to display light chain restriction. Although with pronase digestion, some of those patients have displayed light chain restriction, but you don't have to have that even in the absence of, even if you have pronase digestion, it's still negative. It's still considered to be a monoclonal immunoglobulin-related disease if you do have the MGUS. And then lastly, of course, cryoglobulemic, which was in this case, we were all considering that too with the low C4 and the relatively new microscopic hematuria. So these are all the lesions that can exist. And I think this is a really nice review and so I put it up in the chat. In our case, of course, we just had diabetic nephropathy, none of these, but it's always good to think about. If I had to do it again, she had enough going on that I think even, we typically don't biopsy for diabetes, but I would have biopsied her if I had to do it all again, knowing that she had just too much going on in the differential that was so eloquently discussed before we started.
That's great. What a beautiful figure. And it just tells you, it's incredible that monoclonal immunoglobulins can have so many different patterns of injury in so many different places in the glomerulus in so many different ways with crystals and in absolutely every part. Can be in the mesangium, it can be in the tubule, it can be anywhere. It's really an incredible thing. And a lot of this has just developed and been figured out in the last 15, 10, even less years. So
but
who knows?
people have been looking at this obviously for a long time. The whole idea that some light chains will precipitate out in the tubules, others will get into the basement membrane and basically be, light chain deposition disease and have that granular pattern. Then others have this highly structured beta-pleated sheet, which is amyloid. They're all light chains, but there's obviously clearly something different about them. So that whole issue of what's different about them that causes one thing to lead to another. And for years, people thought, the two didn't coexist. That if you had one lesion, that there wasn't usually another one associated with that light chain. And then the whole issue of light chain deposition disease coexisting with CAS nephropathy and even occasionally amyloid having CAS nephropathy kind of threw that all, which gets, I think, back to the issue that there may be more than one abnormal clone.
Although the majority of these cases, it's an isolated lesion, but yeah, you're absolutely right. But I mean, what it gets to is that we're going to be stuck biopsying a lot of people with monoclonal gammopathies, and monoclonal gammopathies are very common in older patients. And, it's you don't want to miss something treatable, but you don't want to, biopsy everybody either. Bill said it was only 40% or something who had a monoclonal gammopathy that had a lesion that was associated with it.
And that was the 2003 paper. It held true to the 2020 paper, and it was only 20% in patients if they had a history of diabetes.
But my point is that's a lot higher than I would have even figured, since monoclonal gammopathies are so common in elderly patients. So it's not like it's 1 in 10 or something. It's 1 in 5 or 1 in 4 or something. And
but even then, that's the way that's the way you back into this diagnosis. I mean, you look at Mark Haas's paper from years ago, unexplained acute renal failure. I mean, even though vasculitis was the most common cause, the paraprotein associated renal diseases leading to AKI, that's ultimately many times these diagnoses are made by backing into it. And so if you don't chase it down, you'll miss it. And that's the problem.
So
the paper did try to give a little guidance on who to biopsy. They said more commonly on the multivariate analysis, it said, proteinuria greater than 1.5 grams, the presence of hematuria, the degree of the abnormal free light chain ratio were all consistent. Diabetes a little bit less so. And so, but you're right. I mean, if you have somebody with 300 milligrams or maybe 500 milligrams of proteinuria without hematuria, would you biopsy? It's hard to say, but at least that paper would point towards that being an MGUS rather than an MGRS. So they try to use those 3 factors, which was proteinuria, hematuria, and abnormal free light chain ratio.
But would you do a bone marrow?
In this case, no, but I think
in the scenario you're describing, you're kind of left still doing a bone marrow, if not a biopsy, to prove that there's not some sort of a monoclonal, that there's not a myeloma, if you will. It's kind of there's bound to be a abnormal monoclonal chain by definition almost. The question is whether they actually have myeloma.
Well, if there's no end organ damage, then it's probably not as important to find that clone.
Well, then then there lies the problem, because the kidney becomes the end organ, and if you don't biopsy it, you don't know.
Yeah. Well, that's right. That's right. No, that's exactly right.
I mean, if the marrow is negative and you still have a monoclonal in the blood and there is any renal abnormality, I still feel like we ought to biopsy to rule out MGRS, right?
No, that's exactly right.
That's exactly the point of an MGRS, and that's how we're finding them. But again, we're going to be biopsying a lot of people with something else. But
and the problem with that is.
Well, I also think that you can use a little bit of a time course too. If you've had somebody that you're inheriting and they've had their MGUS for 8 years and their creatinine's been stable the whole time, it's hard to argue that there'd be a reason to biopsy. So I think sometimes timing of onset, in this case, we had really no history before 6 months. And so and she kind of went 2 to 2.7 to 5 when she was admitted. So we really didn't have much of a choice. But a lot of times I think you can use the stability of disease to argue against an abnormal MGRS.
Dr. Glassick, do you think that as Dr. Gashty posed in the chat board, do we biopsy every MGUS with any abnormal renal finding?
Well, I'd be interested to know from the Leung paper that you just cited whether there's an element of age stratification, because frequency of MGUS unrelated to kidney disease certainly must be increased in the very elderly. So I would probably say I might be willing to follow a patient with an MGUS and some degree of renal abnormality if they were very elderly, over 75, over 85. They didn't show in their study that age was a factor, but what was the maximum age in the patients they studied?
So I don't know if you can see this here, hopefully. Yeah.
Pretty high, 65 plus 12, 77, yeah.
Yeah.
Seems as though age is not really a very useful factor then. Interesting.
Well, for sure, if someone's young, what is it? Less than 1% of the patients under the age of 40 have any kind of a protein-related problem. So
I'm going to address one more question in the chat. That's when do you perform pronase digestion? Is it frequent that it changes the diagnosis? Well, it may turn out that someday we do pronase digestion. It might become a routine. Right now, it's not a routine, and certain labs are able to do it, and they're often doing it on very special cases that have a question mark, and that does change the diagnosis. But if it's done on every routine case, I don't think it's going to change the diagnosis a lot. But I think if it becomes routine, I think you're going to find a lot of unmasked restriction. But I think the future is going to tell us on that one. I think I'm going to wrap this up. We've hit our hour. I want to thank everybody for coming. It was a great discussion. Thanks a lot, Bill. Happy birthday, Pravir. The CME activity code today is 482-407. Thanks, everybody. Be safe, get vaccinated, and we'll see you all next week.